If you've seen an orthopedic surgeon for a foot or ankle problem in the last 5 years, there's a good chance you were treated by someone who spent less time studying your injury than a medical school student does on a short rotation. I've been doing this for 25 years. A huge chunk of patients who walk through my door come to me after they've already been treated by someone else, an orthopedic surgeon, a general practitioner, sometimes a surgeon who's done a procedure in the foot and ankle for years. They come to me because something didn't work. The problem came back. The surgery didn't hold, or the situation got worse. When you see that pattern hundreds of times, you start wondering whether it's a coincidence. Here's what most patients are never told. The training gap between a podiatrist and orthopedic surgeon for the foot and ankle isn't small. It's not a matter of preference or style. It's a structural difference in medical education that most practitioners, including many orthopedic surgeons, have never had to think carefully about. In this video, I'm going to walk you through exactly how the training differences work, what it means for every category of foot and ankle condition, how to know whether your specialist you're seeing right now is the right one for your problem, and what to do if you suspect the answer is no. Your orthopedic surgeon spent 6 months learning what a podiatrist spent 7 years mastering. Most patients assume an orthopedic surgeon is the gold standard for anything involving bone, joints, ligaments, or tendon. The word orthopedic sounds authoritative. It implies comprehensiveness. And for many parts of the body, an orthopedic surgeon is exactly the right call. The shoulder, the hip, the knee. Orthopedic training is broad and seriously covers a lot of ground. That assumption spreads because most people have no reason to know how medical training is structured. Doctors go to medical school, then residency, and somewhere in that process they become qualified. That's roughly what most people understand. Nobody explains that a podiatric physician went to a completely separate medical school, a specialized institution focused entirely on the foot and ankle, and then completed a surgical residency on top of that. Nobody explains that distinction because in most clinical conversation, it never comes up. Here's the actual structure. A podiatric physician completes 4 years of undergraduate, 4 years of podiatric medical school, 3 years surgical residency. That's 7 years postgraduate training. And in every one of those years, the foot and ankle is the primary subject. The bone structure, the ligament anatomy, the nerve pathways, the skin, the vascular supply, the biomechanics, all of it in extraordinary depth for the entirety of the training. An orthopedic surgeon completes a general medical degree and then a residency in orthopedic surgery. That residency covers the entire musculoskeletal system, the shoulder, the knee, the hip, the spine, the hand, the elbow. The foot and ankle is one rotation within that program. And in most orthopedic residencies, the focused time they spent on the foot and ankle is measured in months, often less than 6. That means a patient with a complex foot or ankle condition may be treated by a surgeon who spent the same amount of time studying for the foot and ankle as a medical school student does on a short clinical rotation. And that patient will never be told this. The surgeon title gives no indication. The clinic's name gives no indication. The referral from the primary care doctor gives no indication. The patient walks in, sees a board-certified orthopedic surgeon, and assumes they're in the most qualified hands available. This isn't an argument that orthopedic surgeons aren't skilled. Many of them are exceptional for the condition they've trained most extensively to treat. The issue is the foot is a highly specialized anatomical region with a level of complexity that rewards deep specialization. When a patient presents with a foot and ankle problem, the question isn't whether their surgeon is talented. The question is whether their surgeon has the depth of training and the breadth of options to manage that specific problem at the highest level. For foot and ankle care, the right starting point is a doctor whose entire medical education was built around that region. A podiatrist isn't a foot doctor in the colloquial sense, a lesser version of a surgeon who handles minor problems. A podiatrist is a regional specialist with more focused training in the foot and ankle than any other category of physician. That's not a marketing statement. That's a structural fact about how podiatric medicine was designed and how the training programs work. I know 5 to 10 approaches to every major condition I treat. When a patient comes to me with a bunion, I'm not looking at one procedure and deciding whether they're qualified for it. I'm looking at the patient's anatomy, their biomechanics, their lifestyle, their bone density, their prior treatment history, and selecting from a range of surgical and conservative approaches that's wider than most orthopedic surgeons carry. That breadth comes directly from training that never left the foot and ankle. When your entire education is focused on one region, you developed options. When your education covers the entire musculoskeletal system, you developed efficiency. And efficiency in a surgeon often means fewer tools applied more broadly. When you understand the training structure, the question of who to see for the foot and ankle problem becomes straightforward. The right answer isn't the surgeon with the most impressive hospital affiliation or the longest wait list. The right answer is the doctor who spent the most concentrated time learning the anatomy you need treated. And that leads to the second thing most patients never understand: what the training gap actually costs them in the exam room and in the operating room. Why the doctor who saved Bill's leg had tools 3 other surgeons didn't even know exist. Most patients believe that if a procedure exists for their condition, the surgeon will know about it and will offer it if it's appropriate. They trust that the menu of options they're giving represents the full range of what's available. They have no reason to believe otherwise. Patients can only compare what they've been offered. If an orthopedic surgeon gives them 2 options and they choose one, they have no visibility into the 3rd, 4th, or 5th option that existed in podiatric training but was never part of their conversation. The absence of options is invisible. You can't miss what was never presented. The range of treatment approaches a physician carries is a direct function of their training. A surgeon trained in broad musculoskeletal curriculum learns the most common approaches for each condition, the techniques that work well enough across a range of patients. A surgeon trained exclusively in foot and ankle medicine learns a far larger library of approaches because the foot and ankle is all they study. That depth produces options, and options produces outcomes that are tailored to the patient rather than fit to the surgeon's available techniques. I had a patient named Bill. He was 58 years old by the time he came to see me. He had been evaluated by 7 other doctors. 3 of them had recommended amputation. He was told by multiple qualified physicians that his leg could not be saved. He came to me as a last resort, with no particular reason to believe the outcome would be different. I used 2 local techniques, approaches that were available to me because the depth of training podiatric medicine requires. His leg was saved. Bill still has a leg because the doctors who came before me had run out of options. I had not. I'm not telling this story to position myself against other physicians. I'm telling it because it's the clearest possible illustration of what happens when training depth determines the size of your toolbox. Bill's previous doctors weren't negligent. They offered everything they had. The problem was that everything they had wasn't enough for that specific case, in that specific anatomy, in that specific clinical situation. The right specialist for the foot and ankle carries more tools for the foot and ankle. That's the only point. The principle is simple. If you only have a hammer, everything looks like a nail. When a surgeon has 1 or 2 approaches to a given condition, patients get those approaches, whether or not it's the best fit. When a surgeon has 10 approaches, the patient gets the one that actually is right for them. The patient-specific matching is what concentrated training produces. And it's what most orthopedic surgeons are structurally unable to provide for complex foot and ankle cases, through no fault of their own. I also treated a patient named Alice. She was 43 years old and came to me with Charcot foot, a serious complex condition involving the collapse of the foot bone structure. After a failed reconstructive attempt at another facility, I performed a staged surgical reconstruction using metallic implants. She returned to regular shoes. That outcome required a level of surgical familiarity with foot anatomy that comes from an education built entirely around it. It's not the kind of case that ends well when it's managed by someone whose foot and ankle training was one chapter in a much larger curriculum. Once you accept that training depth determines option breadth, the calculus changes entirely. Seeing a foot and ankle specialist isn't the conservative course or the cautious one. It's the choice that gives you access to the widest range of options for your specific problem. So the next question is, how do you know whether your specialist you're currently seeing is actually the right one? I'll give you the markers in a moment. If you're finding this useful, subscribe right now. I put out videos specifically for people navigating complex foot and ankle problems. And most of what I cover here is information patients aren't going to get elsewhere. Hit the subscribe button and you'll see it when the next one goes out. 5 questions that reveal whether your specialist actually knows what they're doing. Most patients don't find out they were with the wrong specialist because someone tells them. They find out because the outcome wasn't right. The problem came back, or they happened to see someone else and the conversation was completely different. By that point, months or years have passed. In some cases, an irreversible procedure has already been done. There's a recognizable pattern in patients who come to me after being treated elsewhere. It's not that their previous doctors were careless. It's that the conversation they had was narrow. They were given a diagnosis, offered a limited number of options, moved through the system efficiently. Nobody asked about their full history. Nobody offered multiple approaches. No one explained the reason behind the recommendation in a way that accounted for their specific anatomy or lifestyle. Ask yourself these questions about your current or most recent foot and ankle provider. Were you given more than one treatment option, or was a single approach presented as a default? Did your provider explain why that approach was specific to your anatomy and condition? Were conservative care options discussed alongside with surgical ones, even if surgery was the ultimate recommendation? Has your provider asked about your full history of how the problem developed, including prior treatments and what they did or did not accomplish? Do you know exactly what your diagnosis is and why? Based on a diagnostic workup, or are you given a working assumption? A narrow conversation isn't always a sign of a bad doctor, but in the foot and ankle care specifically, a narrow conversation is often a sign of a doctor working at the edge of the depth for that region. When a physician has 10 approaches to a condition and is thinking carefully about which one fits you, the conversation tends to be wider. When a physician has 1 or 2 approaches in deciding whether you qualify, the conversation tends to be shorter. Knowing you're with the wrong specialist is only useful if you know what to do about it. That's the next point. What do you do the moment you realize you're being treated by the wrong doctor? Changing course in your medical care is uncomfortable. Most patients feel a sense of loyalty to their current provider, or they worry that seeking a second opinion implies distrust. And they've already invested time and money in a treatment path, and they're reluctant to question it. All of that is understandable. None of it should determine whether you get the right care. The patients I see with the best outcomes often are not the ones that came to me first. They're the ones who came to me after something didn't work, and they were willing to start the diagnostic process from the beginning. That willingness is the variable that matters. The diagnosis you received elsewhere may be correct. The treatment plan may need to be reconsidered. Getting a second opinion from a foot and ankle specialist doesn't erase what came before. It adds a layer of depth that in many cases changes everything. I make a point of giving every patient my personal cell phone number, not because I expect every patient to call, but because access is part of care. A patient who can't reach their doctor is a patient who can't get the answer before a small problem becomes a large one. This philosophy is part of what I believe the right specialist relationship looks like. Stop assuming that your board-certified orthopedic surgery is automatically the most qualified person for the foot and ankle problem. The certification is legitimate and meaningful for what it covers. It doesn't cover the foot and ankle at the depth that podiatric training does. Stop waiting for a failed outcome before you ask whether you're with the right specialist. Seek out a podiatric physician for any problem below the knee, including problems you've already had evaluated elsewhere. Ask explicitly about the range of treatment options available for your condition and why the recommended approach fits your specific anatomy. Treat the diagnostic conversation as the foundation, not the formality. The right diagnosis arrived at carefully changes the entire treatment plan. I want to give you something concrete you can do today. The last point is the most practical one in this video. The 15-minute test that'll tell you if your surgeon is guessing and what to ask before your next appointment. Most patients go into medical appointments as receivers of information. The doctor speaks, they listen, they leave with a plan. That's dynamic in that the specialist selects context. It's where the consequential errors get made without anyone noticing it. The way to change that is to arrive with a specific question that requires a specific answer. Not to challenge your provider, but to calibrate whether the conversation you're having is as thorough as your condition warrants. Think about what happens when you bring a car to a mechanic who specializes in one make and model versus a general shop that services everything. Both can diagnose common problems, but when the problem is unusual or when there are multiple ways to address it, the specialist has depth the generalist doesn't. You wouldn't bring a complex engine problem to a shop that sees it twice a year. The foot and ankle is no different. The question is whether the person diagnosing and treating your problem has seen enough of it to know all the ways it can present and all the ways it can be resolved. Patients who ask the right question before the next appointment leave that appointment with a clearer picture of whether they're in the right place. In some cases, one conversation isn't enough to recognize that a different level of specialization is available and worth pursuing. In other cases, the conversation confirms that the current provider has the depth the situation requires. Either outcome is useful. Neither is available to the patient who never asked. Here's what to do with your next foot or ankle appointment. Write down your primary complaint in one sentence, not a summary of your history, one sentence describing the problem that is not resolved. Write down every treatment you have received for this condition, how long ago, and what changed as a result. Include conservative treatment, injections, imaging, and any procedure. Write 3 questions. What is the full range of options for my specific condition? Why is this particular approach the right fit for my anatomy and history? What would need to be true for you to recommend a different approach? At the appointment, listen to whether the provider answers those specific questions. A provider with deep training in the foot and ankle will have specific differentiated answers. A provider working at the edge of their depth will give general answers or will narrow the conversation back to the single approach they've already identified. If you do not get specific answers, contact a podiatric physician for a second evaluation before proceeding with any surgical recommendations. That is the test. It takes 15 minutes to prepare, and it can change the entire trajectory of your care. The foot and ankle is not a simple region of the body, and decisions made about how to treat problems there carry consequences that can last for years. You deserve a specialist whose entire medical education was designed around the anatomy you need treated. That specialists exist, and knowing to ask for them is the most important thing you can take from this video. If you want to understand the full picture of what is happening in foot and ankle care and why so many patients are not getting the outcomes they should be getting, watch this next. This video is called Everything You've Been Told About Diabetic Foot Amputation is Wrong, and it covers something most patients and doctors have never examined closely. The link's right there.